All right, let's get started. Good afternoon. Um, Welcome to our virtual breast cancer symposium. Thank you all for joining today. For those who don't know me, I'm Dr. Jansi Koduri, hematology oncologist with the Dayton Physicians Network. I am presenting this program on behalf of MVAPI, Miami Valley Area Physicians of Indian Origin. And the program today is meant to be an educational program to raise awareness of breast cancer in our communities. It's the last day of October, October 31st today. Important day in many ways. Well, first of all, happy Halloween. And we are about 3 days away from changing the fate of this country. In spite of all that, thank you for joining today to take care of yourselves. October brings painful memories probably for most of us as we have gone through, participated in some of the breast cancer journeys. But it also gives us a joy as we all see breast cancer survivors every day. Now, the goal is to have everybody participate in the screening programs where we can completely prevent breast cancer. And if we have to face this disease, unfortunately, we should know what to do. So most breast cancer patients today survive. Early detection is the key. What once thought to be a death sentence now is viewed as a chronic disease. Because of the new treatment strategies, the breast cancer survival has improved tremendously. So the program today is an opportunity to educate ourselves and hopefully have a deeper understanding of the disease and to know what your treatment options are. Now, probably some of us here has faced breast cancer before. I think we have breast cancer survivors among us, and they're all thinking to themselves, been there, beat that. And that's what we want to hear. Hopefully, this program will be helpful. Do not hesitate to ask your questions. If you look at your screen on the bottom, there is a chat box. All participants, you can type your questions up there. Myself or Jyoti will be asking those questions to the panel on your behalf, which we may do at the end of all the talks, depending on the time. Okay. If somebody wants to say something, they could raise their hand, and Ashwin, who is helping us with this program, can unmute yourself again. That will be at the end of the program. So we will go ahead and get started. Well, I'm privileged to introduce my friend, Dr. Jyoti Chella, who is most famous hematology oncologist in Springfield. She's going to introduce our speakers and start up the program. Take it on.
Hello, everyone. I'm Jyoti Challa. I'm with OHC, Oncology Hematology Care. I work at Springfield. So a little bit about why October and why Pink Ribbon. October is Breast Cancer Awareness Month. And also I was born in October, that's why. I'm just kidding. So October, the National Cancer Awareness Association was founded in October 1985, and that's why October month. And why Pink Ribbon? There's a little story. Let's see. I was always curious to find out why this little ribbon. We see that everywhere in October, especially. So there was this, I think a 68-year-old lady who had her immediate relatives, like her sister, her daughter, her granddaughter. They were all struggling from breast cancer. In 1990s, she actually started producing these peach ribbons in her home for awareness, because she thought that there was very little government funds for cancer, especially breast cancer research and education. And then, I think the editor of this Self magazine, a small magazine editor, Alexandra Penny, she collaborated with the cosmetic giant, Estee, you have to say Estee, not ST, Estee Lauder's CEO, Lauder, who was also a cancer survivor, breast cancer survivor. So they approached this lady, Charlotte Haley, to take upon that idea, but she refused, saying that for commercial reasons, she didn't want to accept that. So they changed the color to pink, and that's how it kind of emerged in 1993, I think. And they sold millions of copies of that magazine, and so this, it's actually a public domain. It's not just to kind of cure the cancer, mammograms, or raise funds. It's to actually make everybody aware of this cancer, and guarantee that treatment is available to everybody, not just women, men, rich or poor, everybody. So without any further delay, I want to introduce our first speaker, the beautiful Dr. Radhika Rajshekar. She's very, very energetic, passionate, very hardworking. I had the privilege of working with her for a brief period of time at VA. Remember, Radhika? And she is a graduate of Kakatiya Medical College, yay, KMC. She's my super junior. And she is with Dayton Physicians, and she's going to talk about risk factors of breast cancer, risk modifications, the screenings, and self-exam, and all that. You can take over, Radhika.
Thank you. Thank you for the kind introduction, Jyoti. It's been a pleasure to work with you always. So without much ado, I will be talking about the breast cancer risk factors and some of the screening guidelines. Today, I'm very glad to be with this esteemed panel. So let's get started. So breast cancer is the leading cause of death among cancer patients worldwide in women. And it's the second leading cause of cancer-related death in women in the United States. It is said 1 in every 8 women will be diagnosed with breast cancer in her lifetime. If you look at it, in men also can have breast cancer. The ratio is 1 in 870. So while it's important to keep men's breast cancer in mind you, if you have a family member who's a man with breast cancer, that becomes very, very important for you to know that, because that's an important risk factor. That brings directly into the risk factors. So being a female alone is a risk factor, and there's not much you can do about it. But you can look at the risk factors for breast cancer in multiple different ways. And you might see a bit of redundancy in my talk, and it is purposefully done because I want to drive a few points home while talking about the risk factors. So you can think of the risk factors for breast cancer as those that are directly linked to cancer genesis within the breast tissue, either because of you being born with a genetic abnormality that increases that risk, or you've been exposed to breast radiation therapy, chest radiation therapy during the important phase of puberty or even your young age. But you can think of the risk factors in other ways too, as those which are vulnerability factors or hormonal factors. Now, those factors are only related to your breast cancers that are feeding off of your hormones. Now, this is not the scope of our talk to go into the finer details of the subtypes of breast cancer, but the most common type is a breast cancer that is dependent on your female hormones. So the longer your body is exposed to those hormones, the higher your risk of developing the hormone-dependent breast cancer. So you having early menses when you're a much younger child, or having a late menopause, or not having had any pregnancy, or not having any lactation, or being exposed to hormone replacement therapy, either because you had an early menopause, or you had a surgical removal of your ovaries, or you have had increased exposure to oral contraceptive pills. All of those will lead to unopposed estrogen activity in your breast and increase the risk of hormone-positive breast cancers. You can think of the risk factors as those which are lifestyle dependent and are contributing to your risk of developing breast cancer, like lack of activity, sedentary lifestyle, obesity, which increases exposure again to estrogen endogenously, or insulin-dependent growth factors that come with obesity, or being exposed to pesticides, smoking, alcohol. All of those contribute to your increased risk of breast cancer. You can see them again, like those which are you're born with, your family history, the genetic abnormalities, and again, the hormonal factors that I mentioned. And if you've had prior even benign breast abnormalities for which you required a biopsy, while they themselves may not be cancerous at this point, but they may increase your risk of developing breast cancer in the future. But the most important way I want you all to think about or look at the risk factors is the risk factors that you have control over and the risk factors that you cannot control. And if you look at it that way, I think the risk factors that you can control gives you a sense of empowerment and control over things that you can do to minimize your risk. So as I said, being a female itself increases your risk of breast cancer, and there's not much you can do about it. And increasing age, again, most cancers, as we all know, are associated in, as we age, you have a higher risk of breast cancer and cancers, and breast cancer is no exception. Patients who are older than 60 have a higher risk of developing breast cancer, but do not forget that breast cancers are seen in much younger patient population. In fact, 1 in every 6th patient with breast cancer is in a younger age group between ages 40 and 49. So very important to remember. And unfortunately, much younger patients, those who are in their early 30s and late 20s, can also be diagnosed with breast cancer. And those are the patients who actually have bad outcomes because their breast cancers tend to be aggressive. Their breast cancers are already in advanced stages and they have poor survival. But anyway, age, your sex, and the race in the families you're born into that you have no control over. Ashkenazi Jewish population, because of higher risk of the BRCA1 and the BRCA2 gene mutation, and in general have a higher risk of most cancers, including breast cancer. Now, while they say statistically Caucasians have a higher risk of breast cancer, but I think that may be skewed because they have a higher access to healthcare and are more diligent in having the screening mammograms. But African American patients and Southeast Asian population also have a higher risk, and they unfortunately get diagnosed at a later date and tend to be diagnosed with an advanced stage and also have poor outcomes. But those are your risks that you have no control over. Then what are some of the risks that you can control? Are the lifestyle dependent risk factors and some of those hormonal factors that we talked about. Increasing your activity. So decreased activity, lack of exercise, obesity, consumption of alcohol, smoking. Those are all some of the risk factors that you can have control over and, if diligent, minimize your risk. Now, coming to chest radiation in patients who have had childhood lymphomas or lymphomas at a younger age or have needed radiation to chest, that may not always be a risk that you have control over, but now we, I think, have measures with just systemic treatment as much as we can, if we could avoid maybe radiation therapy at a younger age group at least, to minimize their risk of acquiring breast cancers in the future. When you're talking about these genetic factors, I want to remind patients that about 70% of the cases are actually sporadic and are not associated with a genetic risk factor. Among the 30 to 40% of the cases that are associated with family history or a gene abnormality, only 5 to 10% are associated with the BRCA1 and the BRCA2 that we can diagnose with genetic testing. In addition to that, there are several other hereditary cancer syndromes that can also be diagnosed. But mind you, about 20 to 25% of them may not necessarily be detected on these genetic tests. So what that does tell you is, yes, you're very diligent. You know about your family members who have had risks of had breast cancer or ovarian cancer or pancreatic, prostate, especially in your immediate family, your first degree relatives. You get tested and you test negative for a gene abnormality. That doesn't automatically take you off the hook, and you're not to be reassured that, okay, well, my gene testing came back negative. I don't have much of a risk of a breast cancer or any of those hereditary cancer syndromes. Not likely. It's just that you don't have those prominent genes that can be tested and we do something about it. You still have a higher risk. So be sure that you do what you have to with your screening mammograms and being very diligent in making sure you're keeping up with these things. And one of the lifestyle things that I wanted to take a moment to talk about is alcohol. I know there is a notion that 1 or 2 wine consumption or alcohol drinks a week is even protective against strokes and heart attacks, but while there may be some truth in it, as far as the risk of cancers is concerned, any amount of alcohol consumption is actually going to increase your risk of not just necessarily the breast cancer, several other cancers. As an example, it only takes 3 to 6 drinks a week to increase your risk of cancer by 15%, and only 14 drinks, I guess that calls for binge drinking over the weekend, but that increases your risk by 51%. So mind you, that's not a negligible risk cancer. And in those who already have breast cancer, especially hormone positive breast cancers, even 1 drink per day increases your risk of having another cancer, mind you, by 90%. So be very, very careful about that. So now that brings to what do? You know you have a risk, all females, and you have to, screen yourself. And that's where the mammogram comes, which is a low density or a low exposure X-ray, basically, to detect your risk of developing breast cancer or detecting early breast cancers. This is a busy slide, but the reason I included it is because we may be hearing a few discrepant advices, whether it is your OBGYN or a primary care physician or specialist, only because different watchdog institutions or organizations have slightly different guidelines as far as mammograms are concerned. If you're going to stick with, my recommendation would be to either go with the American Cancer Society recommendations or the National Comprehensive Cancer Network recommendations, where the American Cancer Society states 40 is an important number, by the way. At age 40, they do recommend start the dialogue about screening mammograms. You do not necessarily meet the criteria to start the mammogram right away, but you have the right to ask it, and you're not wrong in asking for an annual mammogram starting at age 40. But the actual recommendations to start annual mammogram, and again, these recommendations are for patients with average risk, not for those who have higher risk, and we'll come to it in a little bit. But for patients with average risk, which is less than 15% risk of having breast cancer, you have to start the mammogram annually at age 45 and do it every year until age 55. Starting 55 to age 74, you can do it either annually or every 2 years. At age 74, it truly depends on how functional you are and what your life expectancy is. If you're expected to have 10 more years of life expectancy, you can continue on as long as you want. Now, that again varies from what guidelines you follow, but these are in general the general guidelines. So I said 40 is an important number. That's because you start the dialogue for having screening mammograms at that age. And remember, I said 1 in every 6th patient with breast cancer falls in the bracket of 40 to 69. And prior to mammograms, there was a lot of death because there was very little early detection of breast cancers, and there was a lot of morbidity because most of them were going and having to go through mastectomies. With the advent of mammograms, the rate of death of breast cancer-related mortality reduced by 1/3 since 1990, and it was able to reduce the risk of breast cancer death by 40%, not an insignificant number. What about those with higher risk? Those who are either the BRCA1 and the BRCA2 mutation carriers or other high-risk genetic syndromes, or who have had prior chest radiation. These are patients with very high risk for having breast cancer. They cannot be screened by your regular mammograms at age 40. They have to start at age 30, and they not only should have an annual screening mammogram, but that should be coupled with a screening breast MRI every 6 months. Now, if you are diagnosed with, or you have a genetic syndrome, and you have a family member who's diagnosed with breast cancer at, say, age 35, then you start all these measures 10 years younger than the patient with the breast cancer diagnosis. So you would start at age 25 itself. Again, those who might not fit into those high-risk definitions that I said, that is, they are the BRCA1 carriers, or they have had prior just radiation therapy or genetic syndromes, then you have a scientific model that your primary care or your OBGYN can compute and come up with a number and advise you about what kind of screening and at what age you should start. So I said at age 40 is when you routinely start, unless you are a high-risk patient where you could start at age 30 or age 25. But what about those who don't fall under those breast categories? How do they screen? There is nothing like examination. And again, it never takes the place of a mammogram, but you develop a technique and you stick to it, and you do a routine regular breast self-exams. And if you find an abnormality, you seek care and follow that up with imaging studies. So let's see if I can open this link. And let me see if I can. So this just helps explain how to do the self-exam. Try to do it around the same time, and maybe around half your flow period, and try to take a selfie of your previous exam so you have access. In a good light, stand in front of a mirror and at your breast exam. So obviously you are standing straight, shoulders square, and look at the symmetry, any dimpling, any redness, any swelling, any discharge or any rash from the breast, or any changes in your nipple. Is there nipple inversion, or has there been any change? Raise your arms and do the same thing again with your arms bent and straight. It's self-explanatory, like, and examine your left breast with your right and right breast with your left. With deep, just using the flats of your breast, and develop a pattern, whether you start from the medial side of the lateral or lateral to the medium, but just follow the same pattern every time. And then try to do the exam if you could during the shower, because that's when you feel the least bumpiness of it. And again, like I said, never take the breast exam in the place of a mammogram. Let's see if I can go back to my presentation somehow. Yeah. So again, so how do, I guess just a small picture of the mammogram here. Let's go back. So the top one is the normal mammogram. The one next to it, which has slightly speculated appearance, is the typical presentation of how a cancerous tissue appears on a mammogram. Now the cysts are very clear with very dense opacities in the middle, and they have very clear margins, and they are usually not malignant. Those smaller dots that are in the last picture, called the microcalcifications, are sometimes associated with the precancers or the stage 0, what we call as carcinoma in situ. In the mammogram, your breast tissue is compressed either from top to bottom or from side to both sides, taking two different views. And if you have both compressions, it gives you a better picture. There are several different types of mammograms. I don't think we have the scope, but if anybody has a specific question, I'm more than happy to answer. I think I'm almost running out of time here, or running into someone else's time. But no medical talk these days can be completed without talking about the effects of COVID-19. And it has, of course, affected the frequency with which the screening mammograms are being done, and even all aspects of oncology care. Most patients are getting, either delayed in getting their mammograms because they are afraid to come to any kind of medical facilities during this time. But I want to reassure you, these are low-risk radiology procedures, and they should be with minimal risk for acquiring COVID-19 if you are paying attention and doing your due diligence. All radiology departments, outpatient diagnostic centers are being very careful in minimizing, the patients that are in the waiting rooms, sanitizing all the surfaces, and you have to wear your mask and they are wearing the mask, and all of those things. Call ahead of time and schedule it. So I would say, please don't delay getting your mammograms in time because of the COVID-19. And again, that's the same thing here. Thank you everyone for your time. I ran a little over my times, but if you have any questions, I'm happy to take them.
Oh, Radhika, you're not only beautiful, but you have a melodious voice, soothing voice.
Oh gosh, thank you, too kind.
You sing as well?
Well, we'll talk about it.
Jhansi, you have something to add? Are we asking the questions now?
It is an excellent presentation, Radhika. I think we will take the questions at the end for the sake of time. Okay. Maybe we should move on with the next speaker.
Okay. Now we welcome Praveena Cheruvu. I have to tell one thing about her. She's one energetic lady. We used to go to Orange Theory Fitness, Praveena. And man, she's burned like 45, 48, 50 splat points. And I was at like 15, 20. She keeps on going. She's a very, very energetic person. She received her medical degree from University of Texas, Galveston, completed her residency at the same place, and then went on to pursue her fellowship from University of Rochester. And she's with Dayton Physicians now. And she's going to talk a little bit about the staging of breast cancer, the surgical modalities, but mainly dwell on the radiation options. You can take on, Praveena.
Okay, thank you very much. Let me just. Okay, so today I would try to focus a bit about local therapies in breast cancer. So let me just, here we go. So in terms of staging, I just did a generalized overview slide here of, breast cancer staging. Just like in any other cancer, we typically stage cancer from 0 to 4, 4 if it's spread outside the breast typically. And 1 being early stage where it's just focused on the breast. 2 overall, you have the primary breast malignancy or cancer, and it's spreading to the first primary basin of lymph nodes it goes to is typically under the armpit. And 3, if there's multiple areas of lymph nodes involved, and that's what this picture is trying to depict. Typically, like I said, the first course of lymph nodes it goes to is under the armpit, but other areas of lymph nodes regions it couldn't affect is internal mammary, where it's in the middle of the breast, and also supraclavicular and infraclavicular, which is above and below the collarbone. And then 4, of course, if it's spread elsewhere. So an overview of kind of local therapies. So you know, it's obviously different than systemic treatment. So local therapies is the attack of the primary malignant cancer and is, you know, focused on just that. So there's two main modalities in terms of local treatments. You have surgery and of course radiation. In terms of surgery, you know, you have, again, two main approaches. You have more of a breast conserving surgery where, of course, the goal is to preserve the breast, and there's different forms of breast conserving surgery. And then, of course, you have mastectomy where there's entire removal of the breast. And then in terms of radiation, of course, depending on the surgery, that changes, you know, in terms of the field of design. So with the breast conserving surgery, the radiation would be to the whole breast. With the mastectomy, radiation would be directed towards the chest wall, plus or minus the regional nodes, depending on the final pathology. So in terms of mastectomy, of course, I'm not a surgeon, but, you know, with mastectomy, women always have the option of reconstruction. And with reconstruction, it definitely does not limit or change their prognosis or change their treatments afterwards. So if, you know, if that's something they wish to desire to proceed with, obviously, you know, it is definitely an option. Two main surgical approaches in terms of reconstruction is placement of an implant that we have here, this artificial implant that's implanted between the subcutaneous tissue and the pectoralis major muscle, or taking their own tissue, either from the abdomen, hip, that, et cetera, to implant that. So that's their own self tissue that they implant into the breast area. Prior to implant, especially with the implants, prior to inserting the permanent implant, they do at time of the mastectomy insert something they call an expander. And what the purpose of the expander is, basically the reason of it is they've removed so much tissue, now they have to be able to kind of stretch that tissue out to insert an implant. So, you know, definitely, you know, if that's something one should consider, you know, plastic surgery referral is obviously warranted. So in terms of breast conserving surgeries, I mean, of course, not all patients have to undergo a mastectomy. There are certain situations where a mastectomy would be recommended and breast conserving surgery would not be possible. But if breast conserving surgery is an option, they still have very good outcomes, very similar to a mastectomy, especially if they receive radiation therapy afterwards. So the goals of a breast conserving surgery, which they usually refer to as lumpectomy, is to provide equal outcomes to a mastectomy while maintaining a cosmetically acceptable breast. And there are certain contraindications which makes a patient not eligible for breast conserving surgery, one of which being inflammatory breast cancer. And to kind of briefly explain what that is, it's a very aggressive type of breast cancer where you have involvement of the skin with erythema and warmth. Multicentric disease. So what I mean by that is where you have focuses of cancer throughout the breast in multiple quadrants of the breast. So it's unable to kind of encompass in one single excision. Diffuse microcalcifications, Dr. Rajshekar described what calcifications were. So if you have those calcifications on a mammogram throughout the breast, that would be a contraindication for more of a lumpectomy. If they've had a prior history of radiation, either with pediatric lymphoma or had a previous breast cancer and had radiation at that time, that would be a contraindication for breast conserving surgery. Of course, pregnancy. And then the other contraindication would be if they've had positive resection margins despite multiple attempts at surgery. So meaning they were not able to kind of remove it all, always had microscopic cells left behind. So to kind of, again, have a pictorial kind of representation of what breast conserving surgery entails is here you'll have, for example, if you have the primary malignancy, they have an excision of that entire cancer, and they always like to have good margins, so a good area of normal tissue around it to ensure that there's no microscopic cells left behind. And then they also evaluate the lymph nodes. And the first area of lymph nodes it likes to travel is under the armpit. The axillary lymph nodes. And we move towards more of a sentinel lymph node biopsy. And what I mean by that is they inject the dye They identify the primary lymph nodes that the cancer likes to spread to, and those only of which are removed. So typically on average, anywhere between 1 to 3 lymph nodes are removed at time of sentinel lymph node biopsy. The advantage of that is it decreases side effects, which we will discuss later. So I've kind of alluded to this fact, margins of resection. When you have the cancer, we like a good area of normal tissue kind of surrounding that cancer when they remove it. And that's true with any oncologic surgery. And they define margins differently with invasive versus the precancerous lesion. And that's what the DCIS is here represents. So with invasive, as long as there's no tumor on ink, so there is no, when they cut margin, that there's no malignant cells, that is considered as a negative margin, and they're good to go for further treatments. With the DCIS, just because of the way it spreads, we like to see at least 2 millimeters of normal tissue between the final malignancy versus the cut margin. So typically on average in the US, the reoperation rate, so the fact that they have to take them back into surgery for margin status, is about 20 to 25%. And of course, at time of surgery, the surgeons are very diligent in trying to avoid a second surgery. So what they do is, of course, they take pictures mammographically, and they do an intraoperative margin assessment as well with the pathologist to ensure that they've gotten clear margins. And another technique that they commonly use is post-excision cavity shaving, meaning once they remove it, they remove tissue even more to just make sure that they get good margins. So I kind of talked about this briefly, but the axilla. So the first area of lymph nodes it spreads to is under the armpit. And if there are no lymph nodes seen on clinical exam, mammogram, typically the standard of care would be a sentinel lymph node biopsy, where only 1 to 3 lymph nodes are removed. If they have positive lymph nodes on exam, or 3 or more lymph nodes seen on sentinel lymph node biopsy, the surgeon opts to proceed with a axillary dissection, where they remove the entire axilla fat to its best ability, and there are multiple lymph nodes removed. On average, about 10 to 12 lymph nodes are typically removed. So that is what is involved with surgery. So now moving on to radiation. What is radiation? So radiation involves treatment using high energy X-ray beam, typically in the level of photons, and it's directed to a certain target. It acts by damaging cell machinery for growth, either in cell death or cell repair. So in breast cancer, the goal of radiation, you have the primary tumor removed by your surgeon typically by that time, and radiation is more of an added insurance policy. It decreases the local recurrence by 50%, and potentially treating microscopic cells as well. So in terms of radiation, there's two main techniques when we do with breast conserving. You have whole breast, which is pretty much what majority of the patients tend to get, versus partial breast radiation. So with breast radiation, like I mentioned, there's about 50% reduction in 10-year risk of local recurrence, as well as reduction of breast cancer death. And a couple steps happen before the patient actually starts treatment. The first being the CT simulation, where they come in for a CAT scan, and then pretty much, it's half an hour of appointment, and then they go home. Afterwards, there is more of a treatment planning process that occurs with the physician as well as with their physics staff in terms of devising, calculating a plan, and then they get scheduled for their first treatment. So in terms of the CT simulation, the goal of the CAT scan is, because it's so localized, so accurate nowadays, the treatment position is extremely important. It has to be reproducible, comfortable for the patient. And we like to border or outline the entire breast, in this case, the left breast. And typically we have the arms up for treatment. And that's just because, if we have the arm down and we have to get in a field of radiation, we definitely don't want to go through the arm. So that's what's done at time of the CAT scan. And then in terms of treatment planning, it's mainly field arrangement to figure out how to treat the breast while minimizing dose to the normal structures like lung, heart, especially in this area. So this is a picture of a CAT scan that for her right breast was treated. The outline in red represents the lumpectomy cavity. So that's what the fluid-filled cavity after surgery. And then the surgeon here did place a surgical clip, and that's what you see attenuated right at the superior part of the cavity. So that helps us kind of to delineate the lumpectomy cavity. But usually we do treat the entire breast with whole breast radiation, and this represents the whole colored area is pretty much what's receiving at least 95% of the dose. So typically it is the whole breast is treated from 2 tangential fields. You have one coming from the right medial and one is from the right lateral. So of course we don't want to hit straight on because you don't want to affect the lung, which sits right behind it in this case. So with right-sided tumors, I mean, the main thing I look at is the lung dose. It has no effect on the heart since it's on the right side. But for left-sided breast cancers, the story is a bit different. You know, you have the heart sitting kind of fairly close to the breast tissue. So a technique that we use nowadays to reduce the heart dose and the cardiac toxicity that a lot of people talk about is a deep inspiration breath hold. And what I mean by that is, you know, we have patients taking a deep breath in and kind of hold it for 10 to 15 seconds. And the purpose of that is to basically decrease, you know, expand that area between the breast and the heart tissue. So in this CAT scan over here, this is done with deeper inspiration breath hold. And as you can see with this form, like the heart is fairly far apart from the breast tissue, where we were able to get everything in red represents 95% of the dose. So the heart has no effect to it. Even the low dose range even gets not affected by the heart. But if this is a scan with free breathing CAT scan, and so the left ventricle kind of sits right behind that breast tissue, so that in this case, if we treated this person like this way, about 95% of the dose would get to the lateral aspect of the heart. So that's the advantage of doing it in deep inspiration breath hold. So the radiation beam actually just turns on when they are holding their breath. And so we can monitor that throughout treatment. Another way to reduce heart dose, especially for the larger, more pendulous type breast tissues, is to have them lay prone. And the benefit of prone, of course, is that it's kind of like the MRI. They're laying on their belly, and the breast is kind of hanging down there. And the radiation field, it goes directly just to the breast tissue. Everything in this red outline represents what would be treated and what would receive about 95% of the dose. So the heart is, you know, a distance away, doesn't get affected. And the other benefit that I see with prone breast radiation, so, you know, you can still do her deep inspiration breath hold, but the benefit with doing it prone is her skin toxicity is also less with prone, just because of the location of how we're treating this. So whole breast radiation is typically dosed over 6 weeks. It is every day, Monday through Friday, but each treatment's only 10 to 15 minutes long. We've looked at trying to shorten the number of weeks to, you know, reduce travel time. There are hypofractionated regimens, a shorter course over anywhere between like about 21 treatments for small to medium breasted women with early stage breast cancer. Between the two, the hypofractionated or the conventional, there's no difference in outcomes or long-term toxicities. But of course, when we choose something with higher dose per day to kind of shorten the course, you know, we do look at their overall clinical status as well. Like those with breast augmentation or collagen vascular disease, we tend to take them slower over 6 weeks, or if they've received chemotherapy as well. So typically it's about 5 weeks where we treat the whole breast, and then we follow it with an additional week of where it's just directed towards the cavity. So briefly about partial breast radiation, it is another form of treating very early stage breast cancer after breast conserving surgery. Not commonly done, I would say in our practice, we probably have 10 cases per year kind of thing. And the the benefit of accelerated partial breast radiation is just given for 5 days. They come in twice a day, so it's shorter course period, but it's only directed just to the lumpectomy cavity. And there's very strict, stringent criteria to see if a patient would even be a candidate for accelerated partial breast. I've listed them here. You know, they have to be greater than 50 years of age, has to be very small, less than 2 centimeters with node negative, and have very good surgical margins. We do avoid them if they're larger or if they're younger of age. HER2 positive or positive lymph nodes are the most common reasons why we don't prefer to do accelerated partial. But to kind of explain the process is at time of the lumpectomy, the surgeon does place a balloon, and that is fitted right in the lumpectomy cavity. And then they have a catheter basically coming out of the skin. And this catheter, at the end of this catheter, we connect that to tubing that is basically connected to one of our radiation machines. And through this catheter, and it's deposited into the balloon, the radioactive seeds would basically be deposited and giving a good dose formation just around the cavity. So everything in red is what would be treated. Typically, the overall outcomes in terms of survival, recurrence is pretty much the same as a whole breast radiation. The overall cosmesis is better with whole breast though. So in terms of women that have a mastectomy, there are certain indications that would require for them to have radiation as well, especially if they have a large tumor size, positive lymph nodes, or positive margins. And this woman, she had reconstruction. So just to show you that even with reconstruction, you can have whole breast radiation or whole reconstructed breast radiation, as well as, and get good outcomes as well. In certain situations, we also treat the lymph nodes, and it mainly depends on if they've had lymph nodes involved at time of surgery or final pathology. Other aggressive pathologic features also elude us to treat the lymph nodes as well. So the typical areas of lymph nodes that we treat is the high axilla and the area around the collarbone. So in terms of side effects of radiation, the main thing is the skin, kind of like a sunburn type of appearance. The erythema, women can have dry skin. Typically it's a buildup effect, so it's in the latter half of their course of radiation. Another common side effect is fatigue. In terms of late side effects, meaning years after radiation is done, they are more prone to scar tissue, fibrosis, and of course, if they've still preserved their breast, they are at risk for a slightly decreased breast size. And then lymphedema, what that is basically swelling of that arm. And the reason is because of the lymph node drainage, the lack thereof. So if they've had a dissection where they removed multiple nodes and we've treated the axilla with radiation, they are at a higher risk. For early stage, where they just remove 1 to 3 lymph nodes and no effect with radiation, the chance of lymphedema is much, much, much less. So conclusions, local treatments is definitely, plays a vital role with breast cancer treatments. There are newer techniques with reconstructions after mastectomy, so it's definitely an option with mastectomy. Breast conserving therapy does allow women to preserve their breast with very good outcomes. In some cases, we do use neoadjuvant chemotherapy as well to basically make them eligible for breast conserving surgery. After breast conserving surgery, radiation does play an important role, as well as in special cases with the mastectomy. And with radiation, there have been many improvements in technology and techniques to decrease the cardiac toxicity. Thank you.
Ravina, that was an awesome presentation, man, for us guys too. That was very informative.
Sorry if I went over.
That was fine, I think. Now we move on to last but not least speaker. She's none other than Dr. Neetu Radhakrishnan. She earned her degree from Osmania Medical College, Hyderabad. She went on to finish her hematology oncology from Long Island Jewish Medical Center. I think she was for a while associate professor of oncology at University of Cincinnati. Then we were lucky to have her join here in Dayton at Kettering Network. She's currently working at Fort Hamilton. Is that right, Neetu? Can you please unmute?
You have to unmute.
Yes,
Yeah.
right. I'm working at Fort Hamilton Cancer Center.
Yeah. She's a very highly skilled medical oncologist. I have to go and tell that she enjoys dancing and also.
How did you know?
I know, I creeped on your thing, you know. So, and you love, you like Taekwondo?
Oh yeah, I used to do Taekwondo. Yes.
Oh my God, yeah. So, yeah. So she's going to talk mainly about the treatment modalities. So we'll just let her talk.
All right. Okay. So, hello everyone. I'm Neetu Radhakrishnan, medical oncologist. So, what a medical oncologist does is that the medical oncologist is the one that usually does the medicines or chemotherapy that usually is part of the cancer treatment in breast cancer. And one of the things that many of my friends always think is that when they think about breast cancer, they think that it has to be all chemotherapy. And I've heard my friends say, I would never ever get treated for breast cancer. I don't want to get chemotherapy. So that is why the topic of my talk today is not all breast cancer needs chemotherapy. And I hope some of my friends are watching. I'm not so sure, but I do hope they do watch because really not all breast cancer needs chemotherapy. So because this is an AIP event, I thought I would look up breast cancer in India. We're all immigrants here. I mean, not all, but some of us are immigrants here. And we tend to think that breast cancer may not be as common in India. But as I've learned, it is still common in India. And the sad part is that in India, about 60% of breast cancers are detected at an advanced stage. And over the years, I realized it's partly because there's less access to care, but also because there's a lot of stigma about breast cancer, especially in certain parts of India. I was told that they would not tell anyone so that their children would not be rejected marriage proposals. And so I know that there is a lot of stigma there. That is something we will have to gradually change with education. But yes, it is important to realize that there is breast cancer in India and that even pregnant women or lactating women, that is those who are breastfeeding, can have breast cancer, even though that is rare. So some common misconceptions about breast cancer is that, when you go for a mammogram, you say, oh my God, it's going to be so painful. And sometimes, yes, mammograms can be painful, but most times mammograms are actually, the current mammogram techniques are pretty good. I can't say they're painless, but definitely not as bad as before. The other common thought that crosses our mind if we ever hear about cancer is that cancer is a death sentence, and that is also not true, especially in breast cancer, because most of the time, because we have such good treatments in breast cancer, we tend to, breast cancer is very curable nowadays. So actually the chances of survival, if the breast cancer is caught early, is very good. Another thought that often crosses us women is, if there's breast cancer, that means they're going to have to remove the entire breast. And as Dr. Cheru was just talking about, there are so many different techniques that we can do now where we want, you don't lose the breast tissue, you just take that part of the tissue that has the cancer and a little bit around it and some lymph nodes. And so, your body image doesn't have to change a lot, especially if the cancer is caught early. And then from an oncologist standpoint, the question of chemotherapy arises, and chemotherapy always conjures up the picture of a bald woman with no hair and women throwing up. And science has progressed, And we do have different kinds of medicines for breast cancer. Not all of them are chemotherapy. Not everybody loses their hair. In fact, we try really hard that if they don't need chemotherapy, we don't give chemotherapy. And that many of the medicines don't cause nausea. Even chemotherapy, people don't always throw up a lot. I mean, actually, they hardly have throwing up. Nausea may be there, but we have such good nausea pills that many women have no nausea at all. So it is, before I go on to talking about the treatments for breast cancer, I still want to emphasize, just like Radhika was saying, that it is important that we also commit to changes in our environment, lifestyle, less or no alcohol, realize that genetics and family history also plays a role, and then reduce our exposure to carcinogens, the many things that Dr. Rajshekar had talked about. But overall, if we talk about cancer, it is a malignant tumor, which means that there are these cells and they're growing without any reason. Normal tissue would have stopped growing, but this keeps growing, and then they try to escape and spread. So if we look at cancer treatment, it is like, I tell my patients that it's like treating a weed. You want to pull out the weed, that's the surgery. You sterilize the area around it, that's the radiation, so that nothing else grows around it. And then you don't want weeds to have spread spores around the rest of the field, so that the weeds grow far away different from the area where the weed was. And that's why we do chemotherapy or hormone blocking pills to reduce the chance that anything ever grows back. So if there are any seeds that have already spread out, we try and kill them. And so these are some of the parts of breast cancer treatment. There is surgery, there is radiation therapy, and then there is chemotherapy. Sometimes there's hormone blocking therapy, and there's targeted therapy. If we were to divide it, we divide these two into local treatments. That's what Dr. Chervu talked about. And today I will be talking about chemotherapy and hormone blocking therapy and a little bit about targeted therapy, which is my field. So these three are called systemic treatments because they are drugs used to treat breast cancer, and these drugs can reach cancer cells almost anywhere in the body. So that is why it is called systemic. And what it's trying to actually do is, sometimes it is trying to shrink the actual breast cancer in the breast, but many times it is given after treatment, after the surgery, to reduce and kill any floating cells that might be still sticking around that we can't see by even scans. But we know they're there, because that is why if it is not treated, breast cancer comes back 4 or 5 years later. Breast cancer treatment is actually quite complicated because it not only depends upon the type of breast cancer, it depends upon the stage, and it depends upon many special situations. So the type of breast cancer, there are different types of breast cancer, and among them, it also depends upon whether the breast cancer has something called hormone receptors, which are estrogen and progesterone receptors, or whether they have something called a HER2 new protein. So basically they're coated with they have excess HER2 new proteins, and this HER2 new protein makes them grow much faster, or whether they don't have any of these, and those are called triple negative breast cancers. So the treatment approach varies for each. And today I'm not going to go into the details of each because that would make it too complex and long. And today's talk, I believe, is more towards a non-medical audience, so I did not go into it in detail, but we could answer questions if needed. So what is chemotherapy? So chemotherapy is generally IV, although there are some oral chemo pills, but chemotherapy is used mostly after surgery, after all the tumors removed, or sometimes before surgery, to try to kill any cancer cells or shrink them before surgery. So when it's used after surgery, it's called adjuvant therapy. If it's done before surgery, it's called neoadjuvant chemotherapy. But not all women with breast cancer will need chemotherapy. We often use chemotherapy when the breast cancer is stage 4. Stage 4 meaning that it is not only in the breast or the lymph nodes, but it has spread to the bones or the lungs, or many times the cancers come back after the initial surgery and now it is in the bones. And so various spots that cannot be just reached by surgery or radiation, then we have to use a drug that will reach or go through the blood into different parts of the body and kill these cancer cells. There are different kinds of chemotherapy. There's one called adriamycin, another called cytoxin, another called taxotere, as one called paclitaxel. Many different kinds of chemotherapies are there. They do cause side effects such as hair loss, nail changes, mouth sores, loss of appetite, nausea, vomiting, diarrhea. But that is why scientists have put, all the funding that we do for breast cancer, and all the scientists that have spent all their lives in looking into breast cancer research. That is why they have tried to solve this problem. And we have different kinds of targeted therapies for breast cancer. So what is targeted therapy? So when we look at chemotherapy, it's like somebody taking a gun and going into the battlefield and they're just shooting everyone and hoping that you can kill the bad person and try to avoid killing the good people. But eventually, you know that some good people are also going to die. So that is chemotherapy. And that's why we lose hair, there's nausea and different side effects. Whereas targeted therapy means it's like a sniper. So the guy knows exactly where the cancer cell is or the bad person is. They aim for the bad person, they avoid all the good people, and then they hit bullseye because it's targeted for something special on that cancer cell, and it's only going to kill the cancer cell and not the surrounding people. So this is where we are moving towards in breast cancer and many other cancers. It is also called personalized medicine because what we are trying to do is try to choose medicines that will work for that particular kind of cancer that is in that person and not just use the same medicine for everyone. So patients are more likely to get therapies with greater impact, which often have fewer side effects. Probably the most common and probably the first targeted therapy, I would say, was hormone blocking therapy for breast cancer. So even though we call it hormone therapy, it's actually blocking hormones. So it's a hormone blocking therapy for breast cancer because about 2 out of 3 breast cancers are hormone receptor positive. What they mean is they have estrogen receptor or progesterone receptor cells that find the estrogen and progesterone in our body and grow. And so if we can find a drug that can block the estrogen or progesterone, then it will kill any cancer cell that is there. Now, so we talked about this, that they have receptors and they attach to estrogen and progesterone. Most of these medicines are oral pills, but they need to be taken for a long time because unlike chemotherapy where we do 3, 4, 6 cycles and it's done, these kind of cancer cells are slow growing ones that tend to hide. And that's why we tend to tell patients to take the hormone blocking pill for about 5 years or even 10 years if we think that's needed instead of just 6 months. And studies have shown that 5 years is probably a very good time point for many breast cancers to stop treatment, but some people need 10 years. The good thing is, unlike chemotherapy, they don't cause a lot of hair loss, they don't cause nausea, but we are blocking hormones. So since breast cancer mostly happens in women in their 50s and 60s, we do get to hear a lot about the postmenopausal symptoms. So it could cause hot flashes, some mood swings. Some people do really fine, and most of them, studies have shown that exercising through all this really helps manage your menopausal symptoms better. And even in these women who do take these pills that are blocking their hormones even more, even then they're able to manage their menopausal symptoms better when they exercise. Because we do need our hormones for our bone strength, we have to monitor the bone strength and look for osteoporosis. But yeah, it is relatively better, I would say better than chemotherapy. However, one has to take it for a much longer time. The other thing about this is that when we see a breast cancer that is hormone positive, we can't automatically say that all they need is a hormone blocking pill. There are these gene studies that we do. They're called molecular studies. One is called an oncotype score, another is called a mammoprint. what they do is they help us understand how much of this cancer actually is going to get killed with chemotherapy, and and what is the benefit of giving chemotherapy to this person. Is it better to just treat them with hormones, or should we do chemotherapy first followed by hormones? And that is another big step towards personalized medicine that everybody is doing in the last 10 to 15 years. And it has helped us reduce the amount of chemotherapy that we have to prescribe for patients. Another targeted therapy for breast cancer that has been lauded as a wonder drug. When this medicine was presented at one of the major conferences in 2005 at ASCO, the entire audience stood up and clapped after they saw the wonderful results that it had. And that is a drug called trastuzumab. It is a drug that targets breast cancers that have HER2 positive disease. So that means this breast cancer has a protein called HER2. It has a lot more HER2 protein than the other normal cells. And that's why it's called a HER2 positive breast cancer. So it happens in about 20% of all breast cancers. They were generally considered very aggressive cancers. And before these drugs came along, these targeted treatments for HER2 positive breast cancer, we always thought that the prognosis was not as good. But since the advent of trastuzumab, and there are other drugs along with the trastuzumab that we use now, we have learned that we can actually effectively and treat them and cure this cancer, and actually be positive that the cancer will not return. Their cure rates are very, very high. Now, one thing about this HER2 positive breast cancer is that when we do these targeted treatments, we do need to take it, we prescribe it for a year. And initially we have to do it with chemotherapy, then we stop the chemotherapy and only continue the anti-HER2 new drug for the breast cancer. These drugs work differently from chemotherapy drugs, and they often have different side effects. They are still intravenous. Most of them are not oral pills. And these intravenous drugs are called monoclonal antibodies because they attach themselves to an antibody part of the immune system, so that it uses part of our immune system. Tells the immune system, hey, look, I'm going to attach myself to this cancer cell. You come and now attack me, and therefore we'll kill the cancer cell. So it is a wonderful new technology, and it's been around now for about 15 years and very good results. There are also oral tyrosine kinase inhibitors that block HER2 positive breast cancer. They too can be used in different situations. Side effects of HER2 targeted therapy: they don't cause nausea, hair loss, any of the usual side effects. Probably the only side effect that we always talk about is that it could have, in very few cases, decrease the pumping of the heart. Now, what that means is that it doesn't mean heart attack. It just means that it could reduce the pumping of the heart, but usually we are so proactive. We check your heart function every 3 months to make sure that it is not dropping, and the slightest sign that it is dropping, we change treatment or decide on what to do. But yes, there is a 1 to 4% chance that there could be some heart failure with this treatment. But the flip side of that, if you look at it, is that 96% of women go through this 1 year of treatment without any side effects and do fine. They do have side effects from the chemotherapy that I have to initially give them, but after that, it is pretty much easy. So I do like comics. I used to read a lot of comics when I was young. I don't know whether anybody in this group loves comics, but if you do, this is Batgirl, this is Wonder Woman, and this is Supergirl. And for breast cancer, I would say that the anti-HER2 new drugs that we have would be called, I would call them the 3 Supergirls, the superheroes. The first one was trastuzumab, another one was pertuzumab. The third one, called TDM1, has shown wonderful results even in stage 4 breast cancer. And I would say that it is, I would call them girl power. Now, there are other medicines too in breast cancer that we can use. So there's immunotherapy. Everybody probably has seen some commercial or the other online talking about immunotherapy in various cancers. melanomas, kidney cancers, lung cancers. Breast cancer, there is some immunotherapy that we can use, not in every situation, but there is some. And that means the immunotherapy, again, is not chemotherapy. It is trying to get your immune system to fight the cancer cells and kill them. So that's another way. Then there are other different kinds of oral drugs targeting various genes in them so that they only hit the cancer cell that has that gene. And, so overall, there are many new drugs that can help treat breast cancer and that are targeted, aiming just for the cancer cell and trying to avoid damaging the surrounding normal cells. These are a few other drugs, but I think in the interest of time, I will skip. Palbociclib or Ibrance has been marketed a lot on TV. Abemaciclib, ribociclib are all new drugs. So in summary, I would say, if we looked at breast cancer and said, oh, there are different kinds of breast cancer and we look at them as supervillains, I would say we have superheroes to match each of their, with different kinds of powers to match their different bad villain qualities. So if it's triple negative, we have a different treatment. If it's hormone positive, we have Superman, that's tamoxifen, that's one of the hormone blocking drugs. There are aromatase inhibitors. If it's a HER2 new positive breast cancer, we have trastuzumab and many others that can fight the cancers. So in summary, I want to say that when we think about cancer, it is all sometimes very overwhelming and we feel like badness is overtaking us, but we have to remember that there are many, many, many drugs, and breast cancer is one of those fields where women have shown that if we put our mind to it, we can get the money, we can build up funding, we can promote research, and science can bring out wonderful treatments for us. So with that, I think we can kick cancer out of the ballpark, or wham, bang, boom, beat cancer. Of course, we do need clinical trials, funding, research. Patients have to enroll in trials. Family support, patient involvement, keeping a positive attitude is very important for us to get through that initial phase of treatment for breast cancer. But all of that has resulted in high survival rates for breast cancer. Thank you. I'm done.
That is an excellent, excellent presentation, Neetu. Love the Marvel Brothers and superheroes, and wow, right? Boom, boom, bang.
Yes, exactly.
Cancer is gone and we stand up straight. Women stand up for women, women power. Excellent. So we will take some questions. I have one that has come through. This question goes to Pravina, Dr. Cheruvu. Can one forgo surgery and just treat breast cancer with radiation for local therapy option?
To answer that question, no, surgery is definitely required. You would still not, because radiation is more for the kind of microscopic cells and recurrence rate. So you would still need gross tumor removal, and that's through surgery. So radiation is always done after surgery.
Any comments from the panelists?
I agree with Dr. Cheruvu that we can't. So like I said, that weed analogy is what I use, because then you can really understand that if you can't pull the weed out, the radiation or the chemotherapy cannot, or the hormone blocking pills cannot really take out the tiny spores that are there. You have to first take the bulk of the tumor out, and after that, the radiation and the chemotherapy or hormone blocking therapy can get rid of the tiny ones that are there. But just radiation is not able to kill that big a tumor.
Great. So many times when we get mammograms, there is this one thing that people always see on their reports: dense breast tissue. Mammogram is not good to assess your breast cancer risk, talk to your physicians, you may need MRI. And that's pretty much everybody who gets their first mammogram when they turn 40. And then as oncologists, we always get this phone call, what's my next step? So what is your recommendation, Dr. Rajshekar, or anybody?
That is so sure. That is so true. So younger patients tend to have more dense breast tissue, right? So, but these days we have a bit more sensitive mammograms. I think we can resort to. The typical mammogram is the digital mammogram. Previously, they used to use the fine scale mammogram, which was much less sensitive, causing a lot of issues, especially with the dense breast tissue. Much less so with the digital mammograms, but still happens. But the tomosynthesis is probably a little bit better. And if you have a questionable digital mammogram, I think that's the next best thing to do would be the mammogram with the tomosynthesis, because it's the 3D construction. If you still have a questionable finding on it, and if the radiologist obviously recommends that, and if you can't clarify that abnormality on an ultrasound, then you could resort to the breast MRI. But you're right, with the younger patients who have more dense breast tissue, you might run into a trouble, but may not be a bigger issue if you incorporate the tomosynthesis. But if that happens even on that, then you could resort to the MRIs. That's my take on it. Anything else from the panelists?
So I actually face this question a lot of times from women saying that I have very small breasts. Why do I need MRI with mammogram? Doesn't mean that if you have small breasts, you can't have dense breast tissue. So you have to just make them aware that dense tissue means, not just having small breasts, and it doesn't depend upon the size of the breast. So.
Yes, and then the MRI, to get MRIs approved, actually, there are a few criteria. One has to, they assess your risk for having breast cancer, and if it's more than a 20%, I think 15 to 20% risk, only then is the MRI approved. So I agree with Radhika that 3D tomosynthesis techniques are usually very good, because it's like looking at a flip book. What they're doing is they're taking many more images of the breast, and then they overlap them like a flip book. So when you flip a book, and that way they can see any subtle changes in the breast. So they're able to actually do better than a regular mammogram. So yeah, a 3D mammogram in dense breast, those who have dense breast, is definitely very useful to make the radiologists and us feel that we haven't missed anything.
And resorting to the MRIs too often will result in a lot of false positive findings, unnecessary psychological stress, and biopsies that might not be indicated. But as Dr. Radhakrishnan said, you have to have more than 20% risk, so that's the high risk group. Or if you belong to the moderate risk, which is the 15 to 20%, you have to have, a really abnormal finding on a mammogram prior before you can get the MRIs approved and resort to them.
That's great. So how do you know if you're high risk and dense breast tissue patient or not? There are several models that are available where you put your risk factors and one can know what their risk is, and that your physicians, your primary care physicians or gynecologists can help you with identifying your risk factors and then recommend the imaging modality for screening appropriately. Now, we are in this COVID-19 crisis, so that is very scary. And breast cancer journey itself is difficult and scary. Your life has to pause so you can take care of yourself. And then most definitely, we are all telling you, you will move on after that. But if COVID-19 and breast cancer journey has to go hand in hand, that is very difficult. Just because we have pandemic, breast cancer won't stop. We will still have patients coming in. Unfortunately, probably with little more advanced disease than we would usually see because they're delaying on their screening testing. So if you guys can comment on the challenges that you are faced with in treatment of breast cancer with COVID-19.
So if I can take up on that question, majority of the patients with breast cancer, you know, and I can talk about my center, but I was reading through all the other centers as well. The screening got delayed, and majority of the patients got delayed the surgery part. So they were being offered neoadjuvant treatment instead of going to the surgery. So that was one thing. And then in patients who have been already diagnosed with breast cancer, we try to see, without compromising the effectiveness of the treatment, if they can be delayed. You know, if it is a weekly treatment, it can be made 3 weekly, and also to support them with growth factor support, so that even if they get COVID positive, you know, the outcome would not be as severe. I don't think the radiation was ever delayed or any compromise in that matter. And the other things we did in our center is that, you know, of course, all the centers is that, you know, we screen for COVID symptoms, like checking the temperature, were they kind of, you know, in close contact with COVID patients. Also, you know, kind of stagger the appointment times, not allowing the visitors. We kind of, even the chemotherapy suite, we actually offer them individual chemo rooms if we can, or put them, you know, farther than each other. So taking all these precautions, we actually did not go through any delays of treatment in our center. In major centers, I think that was the same case. So major delay was in screening and surgery, I believe, not much of as a treatment part.
Any other comments?
Yeah, just to add to what Dr. Challa has said, I think in the very beginning when this came, when there was very little that most of us even knew, there was a lot of delay in screening. But then at the end, there was like a plethora of patients where everybody is catching up with the screenings and the surgeries were also happening. So there was then all of a sudden a big surge. But as she said, I think the delay is mostly happening at screening and surgery because of the surgical requisites, but not so much at the systemic treatment, and definitely not at radiation treatments, I think.
Yeah, I think we are blessed, especially in our area, in Dayton and other cities around, where we didn't have to share our OR ventilators to COVID patients. And we didn't have the major surge like some of the other places did. So our surgeries were almost on time. It's a challenge on the staff and the caregivers to get through these treatments, but yeah, absolutely great teams and things keep going. What I noticed specifically for patients who were COVID positive and recovered, and we had to go back on chemotherapy, they had more profound cytopenias, where, as Jyoti said, we had to rely more on growth factor supports than before. And then we are learning as we go. So being extremely cautious while we are treating our patients with immunosuppressive agents is the key. And the best part is our patients know how to take care of themselves. They know how to wear a mask when they go out and social distance and follow all the rules. So I think that's why our patients are doing okay in spite of this pandemic. So great team. I think any other questions, Jyoti, that's coming through? Or I don't see anything on the panel, but just one more question to Neetu. A lot of times there is this big scare of chemotherapy, even though we don't do chemotherapy for even 20% of breast cancer patients today. what are the long-term complications that patients have to live with. Typically, there is like this intense 6 months of complications, and people usually move on with their lives. Most side effects are completely reversible, but then there are some that are maybe not so reversible or can have some complications at a later date.
Very good question. So, so let's see. So if we were, there are different types of chemotherapy for breast cancer. So there's, the most common would be when somebody has had their cancer taken out, and basically we are aiming for cure. And so the chemotherapy may be given for somewhere between 5 to 6 months. And the medicines that we choose may vary because sometimes we have to use slightly stronger medicines, and sometimes the medicines can be tapered to, depending on the type of breast cancer, so something that the patient can tolerate very easily. If we look at the ones that we call as the harder chemotherapy, which is Adriamycin, Cytoxan. The Adriamycin can sometimes cause heart failure, so that is one side effect that we look out for, but again, that's very small, like 1% of the chance. The other side effect that can happen about 3 to 5 years later is that some people, about 1% or less than 1% actually, so if 100 women get this drug, maybe less than 1% could get leukemia. And that is one of the main reasons why we actually try really hard to use those molecular tests to decide which patient actually needs chemotherapy and whether they need this kind of chemotherapy. But there is a very, very small risk of leukemia with one of these medicines, which is the Adriamycin. The other long-term side effect that another group of medicines called the taxanes can have is neuropathy, which means that the chemotherapy actually damages a few nerve cells, and that leads to numbness in the fingertips or toes. And in those who are diabetic, it might be that when even though the diabetes was actually killing those nerve cells already, they didn't know about it, but once they got chemotherapy, it kind of came out and didn't go away after the chemotherapy. And that leads to what is known as chronic neuropathy, peripheral neuropathy. Most patients, on the other hand, who if their diabetes is well controlled, usually the neuropathy gets better slowly over time. And 1 year later, it usually is a lot better. 2 years later, they say, I might feel it in the fingertips or nothing at all. Other things about chemotherapy is that it does, if somebody is premenopausal, it can push their ovaries into menopause, which means you can hit early menopause. And that in turn can also cause bone loss or osteoporosis. So there are some other side effects. But the thing in breast cancer is that since, like I said, 2/3 of all breast cancer is hormone driven. The purpose of chemotherapy in breast cancer often is to actually make the person stop their ovaries from making the hormones so that it will actually help treat and cure the breast cancer. So yes, it does push people into menopause earlier, but sometimes that is also good for the breast cancer. The thing, Jansi, are there any other side effects that I have not remembered to talk about?
No, I think you did a pretty good job of putting everything together. I think long-term complications are not common at all. They do exist. I think you explained it very well. How about chemo brain?
Chemo brain, yes.
Is it chemo brain? Is it real?
I think it's real. I think chemo brain is real. It varies, and you cannot predict who gets chemo brain, because I've had very young women get chemo brain. I've had, so it varies. But yes, I do feel like there is chemo brain. Some people get better after the chemo is all done, and maybe 5-6 months later, they feel like they're almost back to normal. And some people still say that they feel a little foggy. So I tend to believe women. I'm one of those doctors who I always tell my patient, well, it may not be the treatment, but I'm not definitely discounting anything. Because I think we're all different. We are, we tend to tolerate medicines differently, all of us.
Yeah, I think we see that a lot, just fogginess as they go through chemo. And if your patients come tell you something, it's real, pay attention, and it does get better. Great, great, yeah. Any other questions?
Or enroll them in a clinical study with Aricept as ongoing. I think there is a
Yes.
study going on.
Do you have one open?
So
Yes.
we do have a study open.
We do have one open, yeah. So one very important message, we don't want to go through breast cancer journey, but 1 among 8 women will have the diagnosis of breast cancer in their lifetime. So it is good to be prepared, and it is always good to look into participating in clinical trials. So when you are talking with your physicians, ask them if there are any clinical trials, and the ARCEP trial is one of them. But there are usually several trials, and that's how we learn and better our treatments.
Yeah.
What is stage 0 breast cancer? That's what I got right there.
That's a very good question. I actually wanted to talk about it, but then I thought it was too much to go into, yeah. But yeah, stage 0 breast cancer would be that there are some cancer cells. If you let them go, they will start. So we look at cells. There is a barrier called a basement membrane. If the cells break through and start spreading through what is known as the normal walls in tissue lines, then it becomes stage 1, or goes on to become higher stages. Stage 0 means that these cells do look cancerous, but they're kind of contained in their area. They haven't broken through the walls. They haven't started spreading through. And so 20 years ago, we used to treat them, we used to do the surgery and then do radiation. We often didn't even do hormone blocking pills. But nowadays we know that if some people do, it does come back again. So we do hormone blocking pills. Overall, stage 0 breast cancer has a very, very, very good prognosis in that 99% or more people will be cured forever. Probably 99.5% or something like that. But nevertheless, with mammograms, we tend to diagnose them more and more nowadays, because mammograms are very good at picking up breast cancer at early stages. So we see a lot more stage 0 breast cancer, but it has got a very good prognosis usually. It just means that the breast tissue is more prone to breast cancer. So that person needs to be careful about getting their mammograms every year and trying to reduce, any risk factors in their lifestyle, alcohol, obesity, high red meat diet, things like that they can help. Whatever is in our hands, we try to control it. Pravina, would you like to say anything?
No, I mean, I fully agree. That was a good representation of what stage 0 or DCIS is. But yeah, it has like an excellent outcome, and even radiation. I mean, it really depends. Certain situations, depending on the pathology, radiation could be omitted as well. But again, it really depends on a case-by-case scenario.
There are some DCIs that could probably be left without treatment, but nobody's prepared to take that chance unless there is a real reason for why we shouldn't treat the patient.
Yep.
Excellent explanation. So stage 0 breast cancer is breast cancer. So, but can be completely eliminated by local treatments, and predicts a higher risk of second breast cancer. So you need treatment to prevent that. Very well said. Yeah. Any other questions, or is it time for us to wrap it up? If
I think the trick-or-treaters will be coming soon.
Okay, I'm coming to you. for a chocolate.
Kit Kats. I have Kit Kats.
Okay, on my way. So thank you all for attending our program. Thank you to all the speakers for spending your valuable Saturday evening with us. Thank you, Dr. Radhika Rajshekar, Dr. Praveena Charu, Dr. Neetu Radhakrishnan for your wonderful, most informative topics. Please be ready for some phone calls with more questions.
Always.
And Dr. Jyoti Chella, thank you so much for your help, support in moderating and helping our speakers with their presentations today. The most important, there is always a woman behind a man something, right? But behind this program, we have a man. Thank you, Ashwin Rao, for helping with the technical support to put this program together. And helping us through the program. Thank you so much. Everybody that is listening, please do not hesitate to reach out to us with any questions, concerns, anytime. All our physicians at MVAPI are fully committed to the health and well-being of our community. Never hesitate to reach out to us. Thank you so much. Any comments?
Thank you very much, Jansi.
Thank you. Thank you.
Thank you
Have a good
all.
trick or treat.
So now we can go
Trick or
along with
treat.
our
Not treating.
Halloween costumes and trick-or-treating.
Yes.
Thank you all. Bye.
Bye.
Bye.